everyone, my name is Lauren Albertine. I am a nurse practitioner at the West Cancer Center and am here today to discuss geriatric assessments with everyone. So let's get started. So, a geriatric assessment is a useful tool to guide decision making and improve outcomes in geriatric oncology. It's a systemic evaluation of areas where older patients often have deficits, including functional, emotional, and nutritional status, mobility, fall history, cognition, comorbidities, polypharmacy, and social support. This helps identify at risk patients and individually tailor their oncologic treatment. The results of a geriatric assessment should help inform cancer treatment decision making and address patient impairments through appropriate interventions, counseling, and or referrals. So the great thing with the geriatric assessment is if you're getting these before you start treatment and are able to identify some areas of impairment for a patient, you can go ahead and make some referrals and intervene to try to improve their outcomes on the geriatric assessment before you even get started. So, geriatric assessments have been found to be so helpful in improving patient outcomes that the 2018 ASCO guidelines now recommend geriatric assessments in all patients with cancer over the age of 65. It was recommended that the assessment be done before the start of treatment as well as throughout their treatment journey, as patient status will often change. Unfortunately, due to perceived lack of resources, logistical concerns, and time constraints, geriatric assessments are historically underutilized in oncology. So, the majority of patients with cancer are over the age of 65, so this is a tool that we should be using frequently. And as a reminder, chronological age alone is not a reliable indicator of a patient's resiliency. For example, a 66-year-old patient with many comorbidities could end up scoring worse on a geriatric assessment than a 90-year-old in good health. Therefore, geriatric assessments can help identify those patients that are at risk and also advocates for more aggressive treatment when it's needed in older patients. For example, I once did a geriatric assessment on a patient over age 90 who did have a curable cancer, but the treatment for it was going to be very aggressive. He scored fantastic on his geriatric assessment. So I was able to go to his provider and let him know that I felt confident that he would be able to at least trial the heavy chemo, and he actually did do very well. So that was a place where a geriatric assessment really actually advocated for more aggressive treatment in an older patient. It's also important to remember that traditional treatment algorithms and plans may not always be applicable in this patient population, as they are often underrepresented in clinical trials. A geriatric assessment can help guide the patient, family, and provider in a shared decision-making process regarding best treatment options unique to that particular patient. But I always tell patients when they get referred to me for a geriatric assessment is that we are doing this to try to help individualize their care. We don't want to give treatment like we're just treating anybody. We want to make it as specific to that person as possible. And it really helps them get on board with what we're doing with the geriatric assessment once they have that understanding of why we're doing it. And having this information also really helps the provider have data to support their decisions as they're trying to give them their options for treatment. For example, being able to show a family that the patient scored a 95% likelihood of having toxicities to chemotherapy helps the patient and family better understand why the provider might want to start with an alternative strategy or reduce dosing of chemotherapy at the onset of their treatment. The value of a geriatric assessment is not limited to the medical oncology field also. It can be used in radiation oncology and surgical oncology. I actually have a breast surgeon who frequently refers patients to me to do a geriatric assessment as he's trying to make decisions on if they're going to be a good surgical candidate or not. So it can be used in multiple different modalities as well. Ultimately, a geriatric assessment helps empower the patient to take an active role in their cancer care. So let's move forward with kind of what's included in a geriatric assessment. So it's all going to start with data collection. We start by getting a miniature cognitive assessment, which is a standardized tool that can be accessed for free on the internet, so anyone can do this to assess cognitive status. The next thing I have the patient do is fill out something called a care survey, which I'll break down a little more in depth in just a minute. And then I do a review of their past medical history as well as a review of their current lab work. I use that information to put together two calculators. One is called a chemotherapy toxicity risk calculator, and the other is a general life expectancy predictor tool. So let's take a closer look at some of these things. So this is just a picture of the cognitive assessment. Like I said, it's easily accessed online and will give you a score 1 through 5 on someone's cognition and can help you screen for dementia, which is certainly important when you're making decisions about someone's treatment. You want to make sure that they are able to appropriately make decisions for themselves. Next, we have our care survey. So the survey is about 11 pages. This is just a quick snippet of the front of the survey, and it helps really get some broken down information from the patient about their past medical history, if they've recently been in the hospital, their opinion on their own health, their ability to complete their activities of daily living, what kind of support they have at home, nutritional status, mood assessment, as well as just some functional questions about how they do things outside of the home. So, like I said, I take that cognitive assessment, that care survey, along with a breakdown of their most recent lab work and past medical history, and I'm able to put together these calculators, starting with the chemotherapy toxicity calculator. And basically, it gives you a prediction of their toxicity risk based on if they'll be receiving poly or monotherapy treatment or standard dose treatment or reduced dose treatment. So I really like actually getting all 4 of the available combinations because I can show the provider if they start with standard dosing, multiple drug chemotherapy regimen, if that's a high percentage risk of toxicity, I can also give them what it would be if they would reduce that dose. So I have seen providers start with their polytherapy, but do maybe a 25% dose reduction on the first cycle if it looked like the patient had a high risk of toxicity, just to make sure they see how they do at that reduced dose. And maybe down the line, they'll be able to increase to standard of care or to standard dosing if the patient does well. And next, I do the predicted life expectancy. And this can be really helpful when you're trying to decide on aggressiveness of treatment. And it can also be really helpful with the patient when they are deciding how aggressive they want to be in treating their cancer, if they have a general idea of how much time they might have left. So let's do a couple of case studies to break down how this works in real time. So this was a 75-year-old Caucasian male with muscle invasive bladder cancer. And the physician was trying to decide how aggressive he wanted to be in terms of doing neoadjuvant chemotherapy followed by a cystectomy. As this man, though, not extremely elderly, did have several comorbidities at play. So we did the geriatric assessment and he was cognitively intact, but his chemotherapy toxicity risk did show that he was 90% likely to be toxic to standard dosing polytherapy chemotherapy. But his life expectancy was predicted at 8.9 to 10 years. So with this information, the patient and provider worked together and decided that he was motivated to press on aggressively, knowing that there was a likelihood that we were going to need to support him through some side effects. So we did go ahead and give him neoadjuvant chemotherapy up front, and he did have quite a hard time with it. But what we did was do split dosing to where he was still getting his full regimen, but we broke up the chemo over day 1 and day 8 of the regimen to try to help him get through it a little bit better. And it did help with his pancytopenia and some of his other side effects to have that broken down, and just having the motivation to proceed, knowing his life expectancy was a pretty long time if we were able to get him through this through this cancer treatment. So he did follow his chemo and was able to get all 4 of his cycles and get a cystectomy, and really did very well after he had his surgery once we got him through that chemo. So the geriatric assessment really helped empower him to make that decision in his care. So let's move on to our next patient. Was a 92-year-old Caucasian male with metastatic muscle invasive bladder cancer. So another one where we did a geriatric assessment. He was also found to be cognitively intact. And here's a good example where even though, this man was significantly older than the previous patient, he actually scored better on his chemotherapy toxicity risk assessment. So still relatively high for standard dose polytherapy at 86%, but we found that risk was reduced to 78% if we did a dose reduction of his polytherapy. Now, his life expectancy was at 3.8 to 5.1 years. So when we went into making treatment decisions, the patient was motivated to be aggressive with his treatment, but the provider decided to start treatment with a 25% dose reduction of the chemotherapy and have a very low threshold to change therapy if it was becoming too toxic to the patient. So for this patient, he ended up getting 3 cycles of the chemotherapy. He did have a very hard time with it and decided at that time to go ahead and switch to maintenance immunotherapy and obviously just monotherapy here, and did much better. So the geriatric assessment, though the patient decided he still wanted to be aggressive, it allowed him and the provider to know that there was a good chance they might need to change game plans quickly, and that's what was done to help the patient and improve outcomes. So the moral of the story here is that geriatric assessments can improve outcomes in the older patient population by better tailoring their cancer care, as well as optimizing and providing support for issues identified in the assessment. The challenge now is making sure that it actually gets implemented in daily oncology practice. So in our clinic, the way it's worked most of the time is that providers will see a patient maybe at their new consult, and then refer them to me and my clinic to do the geriatric assessment at another time. That way, that time's already built into my day to have time to get this done, as it can be a long process to do all these calculators and get all of this information. However, it doesn't have to be done that way if you don't have someone in your particular clinic who has the ability to absorb that into their day-to-day. It can be done in real time. It certainly does not have to be done by a provider. It could be, you could have the survey be done and plugged into the calculators by just someone in your team. I think the reason providers don't do that as often is it's hard to stop in the middle of the day and utilize that time and, even your patient room and resources. But if you have a clinic where you have time to do that, I think it's great for the patient and the provider to get that in real time. But at the end of the day, it doesn't matter how it gets done. You just want to make sure that this is being offered and is available to your elderly patients, because it can significantly improve their outcomes. So as long as there is not any questions, that is all that I have for us today, and hope y'all have a great rest of the conference.